Welcome. Today we will be discussing faith community nursing. This lecture will discuss the history of parish nursing, forms of parish nursing, compare and contrast parish nursing with community health nursing, incorporate Healthy People 2020 goals, and cover ethical principles in nursing. We will first start off by watching a short video that gives us an introduction into the topic. I would imagine nurses who serve the faith community enter this modality of nursing because they are deeply rooted in his or her faith. The history of faith community nursing. Faith community nursing was founded by Granger Westberg in the 1980s, just a few decades ago. Granger was a pioneer in exploring and encouraging the interrelationship of religion and medicine and in fostering holistic health care. He founded parish nursing, which is now commonly referred to as faith community nursing. So what has led him to the establishment of faith community nursing? As with most things, there is a need. He made two observations in which he based the program. The first is that churches have lots of nurses. I'm not sure about your church, but mine has at least 2 nurse practitioners, 2 physicians, and at least 2 other nurses besides myself that I am aware of. The second observation is that nurses form an informal network. People go to them for advice or information. When people find out that you're a nurse, they all come to you for advice in any setting. There is sort of an informal network within my congregation. Most of us have worked at the clinic or university hospital. So we've worked together and served the same communities. When a parishioner passes out in church, which happens, we all go running. And so then others then identify who we are, and this is how that network is formed. When we meet with Lori Joseph at St. Mary's Parish in Hudson, you will see how she puts this network of nurses to use in order to benefit the congregation. Some of these quotes on the slide exemplify the fundamentals of faith community nursing. Healing the heart, soul, and body through planning, support, and health promotion. Parish nursing is described as a specialty practice of nursing, having RNs contribute to the health and wholeness of people in the context of a faith community. Health, healing, and wholeness are common themes among those who practice parish nursing. The parish nurse is part of the ministry staff of the congregation and serves the illness needs of individual people, families, and the entire faith community. Parish nurses provide primary, secondary, and tertiary prevention activities. We will discuss more about this later in the lecture, but some examples are setting up health screenings, health teaching, or health promotion within the faith community. Faith community nursing has the same meaning as parish nursing, but faith community nursing has become the preferred generalized term. Let's take a look at some of the benefits of having a faith community nurse. Faith community nursing allows the congregation ease of access to health information through the utilization of services or directly speaking with the faith community nurse. The faith community nurse is there interacting among the faith community. Faith community nurses mesh health and spirituality for a holistic approach. Remember, this is a setting where it is okay to express those values, beliefs, and cultural practices that support or enhance health and well-being. The faith community nurse focuses on the intentional care of the spirit and promotion of holistic health. Lastly, having a faith community nurse promotes a personal responsibility for health care on the part of the individual community member. This is something we talked about way back in week 1, the belief that if a person has a vested interest in their health, they will do more to maintain it. Spiritual health can be a big part of healing. Here, they take the responsibility by actively seeking the faith community nurse or participating in health and wellness activities supported by the faith community nurse. The faith community nurse versus community health nurses. The faith community nurse and the community health nurse. You may be asking, what's the difference? There are some similarities and differences. A community health nurse can do pretty much all of the tasks that a faith community nurse does, but the faith community nurse does not provide hands-on care or provide those technical nursing skills such as dressing changes, injections, blood draws, and medication administration. You may see the faith community nurse assisting with screening blood pressure or blood glucose, but these would be more related to the health promotion role of the faith community nurse. The hyperlink provides information on services Mercy Medical Center offers to its faith community by the practicing faith community nurse. There are two models of faith community practice. The first is the congregational-based model. The congregation commits to supporting the program and therefore supports the concept of faith-based nursing. The nurse is named part of the ministry or congregational staff. This can be a paid or unpaid position. There are advantages and disadvantages to both. In a paid position, they are hired by the faith community to provide faith community nursing services. The nurse has a job description, advisors, and is evaluated. An advantage here is that the congregation is committed to supporting the program because they are buying in or paying for those services. One disadvantage is that some members of the congregation may not fully understand the role and scope of practice of that faith community nurse. In an unpaid position, the faith community nurse volunteers services in the congregational setting, providing that same care as the paid faith community nurse. They may still have advisors, a job description, and evaluation methods. However, they may not be named as part of the ministry staff or board. This becomes a disadvantage when seeking change or developing the program further. In other words, how much say would this person have if they were not a member of the vestry? Who would support them or their ideas? One advantage of this unpaid position is that the nurse may still be able to work in the clinical setting and keep up nursing skills. In both of these positions, paid and unpaid, the nurse typically works independently. The second model is the institution-based model. Here, the nurse serves to coordinate care, particularly at a time of transition or discharge. This is because they are employed by a health system, hospital, or community agency. For example, a faith-based hospital, such as Mercy Hospital, St. Elizabeth's Hospital in Youngstown, or Marymount Hospital in Cleveland. They are assigned to a particular congregational setting, even though they may not be a member of that mosque, synagogue, or church. Again, they are employed by a health system to provide faith-based care. In this model, the faith community nurse is a liaison between the health system and the congregation, assisting the members in utilizing services appropriately or recommending healthcare services. You should be able to differentiate between the two models, congregational-based and institutional-based. The faith community nurse levels of prevention. The faith community nurse engages in primary, secondary, and tertiary prevention methods within the faith community. You should be able to recognize and apply the levels of prevention to faith community nursing. Primary prevention methods would include smoking cessation programs and heart-healthy programs. Secondary prevention would include blood pressure screenings or mobile mammograms that would show up at the church on possibly a designated health fair or a Saturday screening. Tertiary prevention methods include minimizing health problems and maximizing function and recovery. Practice question. Which is an example of a tertiary prevention strategy that a nurse might implement or facilitate for members of a faith community? A program on radon detection in the home. B, a class on cooking nutritious food. C, an occupational therapy program for patients recovering from strokes. Or D, a water aerobics class for seniors. The correct answer is C, because the preventative measure is geared towards rehabilitation, which is a primary goal of tertiary prevention. Healthy People 2020 and the Faith Community Nurse. The information that I am discussing is located on page 492 of your Harkness and DeMarco text. How are these two related? All of the leading health indicators listed in Healthy People 2020 can be addressed by the faith community nurse within the parish or faith community. The leading health indicators of Healthy People 2020 are physical activity, obesity, substance abuse, mental health, injury and violence, and access to care. How does the faith community nurse meet these objectives for prevention and health promotion? They can organize health promotion programs, such as organizing hiking or biking groups, offering jazzercise at the church or parish, and providing health education materials, which can be displayed at the church or parish hall. Churches are often the site of support groups such as AA, Alcoholics Anonymous. Hosting this provides community outreach and speaks to that goal of substance abuse. Mental health and partner, elder, child abuse can be hidden issues. The faith community nurse needs to be alert to abuse and identify any signs of this within the faith community. Once alert to any concerns, they can assist in making the appropriate referrals. Having the knowledge and insight into who may be at risk within the faith community can assist in determining support, referrals, and assistance. Again, Lori Joseph from the parish in Hudson meets the leading health indicators for Healthy People 2020 through health promotion programs and support groups offered to the parish. Faith community nursing process. The nursing process is the basis of the caring relationship. The purpose of the assessment is to provide a baseline of data to support planning. The assessment can be individual, or it may encompass the family. Some examples of an individual assessment are blood pressure monitoring and a home safety assessment. An individual distress assessment may be done with someone who is newly widowed. Family assessments performed include a stress assessment. This can be done with a family after they have a new baby. When assessing the faith community nurse would ask the following. What are the common health problems experienced by the members of this community? Doing this, they can begin to see the patterns that affect the congregation as a whole. A second question the faith community nurse may ask about their community. What are the demographic groups in the congregation? Is it an elderly population, or are there a lot of young mothers? And the third question in assessment, what are the health assets of the faith community? Who are the volunteers or those who are specially trained to assist and support? The fourth question, what environmental health concerns exist in the congregation? Most members of the congregation live within the community. So this goes back to those environmental concepts of environmental justice. Assessment leads to diagnosis. There are some nursing diagnoses that are appropriate in the faith community setting. These diagnoses are set up and updated by the North American Nursing Diagnosis Association International. Examples of diagnosis would be, and these are found on page 495 in box 23.3. Some examples would be ineffective health maintenance, risk for loneliness, caregiver role strain, powerlessness, and lack of health-seeking behaviors. Interventions and outcomes. Before choosing an intervention, it is important to determine which outcomes are achievable. When working with the faith community, one may need to consider the entire faith community, an entire family, or individualize interventions and outcomes. These outcomes and interventions, whether they are individualized or not, are based on culture, values, and beliefs of those within the faith community. Once you determine your outcome, you can choose an intervention that is most appropriate for achieving the goal. For example, the faith nurse determines that the members of the faith community are at risk for cardiovascular illness. Then the nurse needs to plan programs that will achieve the outcome of possibly increasing knowledge about cardiac-related health or decrease illnesses related to heart health. Some programs might include blood pressure, cholesterol screenings, or exercise programs at the church or parish. In evaluation, there's always the need to evaluate, asking ourselves, were the outcomes met for the members of the faith community? It is important to document these outcomes. With documentation, you can illustrate how the faith community nurse was able to impact the community through specific interventions. Roles of the faith community nurse. In an effort to combine faith and healing, the faith community nurse engages in therapeutic listening or does a spiritual assessment. As a personal health counselor, they provide individual health teaching or assess for emotional distress. Education can be done in a variety of settings, such as the home, a healthcare center, or a church, mosque, or temple. As a health advocate, they are empowering the members of the congregation to improve the health of the community. The faith community nurse is unique in this situation because they have established a relationship or have one that is ongoing with the congregation. They are a referral agent and participate in home care referrals. They are coordinators of volunteers. Some responsibilities may include recruiting, training volunteers, and scheduling volunteers for certain services. Access support groups. The faith community nurse can refer members to support groups or be involved with the development of a support group based on the need of the congregation. The goal of the faith community nurse is to empower the faith community and provide spiritual care based in the belief system or structures of the congregation in any denomination. Ethical considerations. Ethics is an important concept in all aspects of nursing. Your textbook devotes a small part to the topic in relation to faith community nursing. You should familiarize yourself with the ethical concepts we are talking about here today. I have included a link at the bottom of the page of some of the most common ethical concepts. Even though everyone within the faith community shares the same beliefs and values, the faith nurse is still challenged to provide ethical care. Let's discuss some of the common ethical principles and how they relate to faith community nursing. The first principle is autonomy. The faith community nurse works to empower the members of the congregation to take charge of their health. Having autonomy means making decisions about health and well-being that are free of coercion and coaxing. It is difficult to see how in the faith community this might occur when everyone is sharing the same belief system. An example that I've provided about autonomy relates to the faith community nurse within the institutional setting. So within our scenario, we have a patient who comes to our department for a procedure. They don't really know about the procedure. No one has told them. They're coming right into the procedural room itself. They're told that they need an IVC filter, which is a life-saving procedure to be done because they have developed a blood clot in their leg. The patient is in their 90s and they have had multiple medical problems. The patient is also a DNR. Now the physician has ordered the procedure. The patient's in our procedure room and the doctor or physician is there telling them that they need to have this done in order to save their life. The patient is unsure and has not had a chance to speak with the family. You notice that the patient is clutching a rosary or religious relic. There's a couple things going on here. Are we taking away the patient's autonomy? Are we using coercion and making this patient have the procedure that maybe they don't want done? What can we do for the patient? Well, we need to advocate. Listen to the patient. An institutional faith-based nurse could help facilitate or advocate for the patient in this scenario. Moving on, our next key term is beneficence. It is the act or intent of doing good for the patient or faith community. The faith nurse is guided by beneficence. The next term is non-maleficence, doing no harm, or at least minimizing harm, by pursuing the greater good. The term confidentiality. The parish nurse is bound to professional confidentiality and privacy, which is becoming even more difficult with advances in communication and technology. I included the link here for the American Nurses Association position on privacy and confidentiality. How does this apply to the faith community nurse? The nurse may find themselves in a challenging position when talking to other members of the congregation who are asking how a person is doing. Why? Well, it might be a tight-knit faith community or a small parish. How can the faith community nurse protect the confidentiality of the other members and still be tactful? Any guesses? Well, in my scenario or example, the faith community nurse can explain to the parishioners simply, confidentiality will be maintained for all members. However, this may not be enough for some. What else could they tell another parishioner in an effort to protect the confidentiality of that parish member? You could tell those concerned, how about sending them a card, calling, or stopping by for a visit? This takes the faith community nurse out of the equation and still maintains confidentiality. These ethical principles guide nursing judgment and decision-making. Overall, the emphasis of the faith community nurse is on the wellness of the mind, body, and spirit of the faith community. Please watch the short video on faith community nursing. This will conclude our lecture for today. I hope that you enjoyed it, and please, as always, do not hesitate to ask me any questions, and have a great day.